Hello, my name is Sean England and I'm a PhD student with the University of Hertfordshire. I'd just like to start off by thanking the CO Research Trust for inviting me to lecture, and thank you all for attending. So as you can see, my lecture is entitled Pupillometry as a Biomarker for Carbon Monoxide Diagnosis. So I presented very similar information at this year's CO Research Trust conference, and this lecture will be an expansion on the information I presented there. So let's get started. To begin with, I'm just going to talk a bit about what exactly is pupillometry. I'm sure a lot of you are wondering, maybe never heard of it before. I hadn't heard of it prior to starting the PhD. I'm going to talk about what it is, a bit about the history of it, the different forms it comes in nowadays, and what kind of data is produced when you actually perform a pupillometry study. So what is pupillometry? Pupillometry is the measurement of pupil diameter and reactivity in response to a stimulus. You can use different types of stimuli to elicit a pupillary response. For instance, you could use light to stimulate the pupillary light reflex. You can use near fixation to stimulate the pupil near response. Or you could even promote cognitive activity to stimulate the psychosensory pupil response, which is often used in psychological research and is currently what dominates the pupillometry field. For the purpose of my project and the lecture as a whole, I'm going to concentrate on the use of light as a stimulus. I've included a GIF on the side, some images we've collected that just demonstrates the kind of images you collect in a pupillometer. The small dots of light you can see are just reflections of the infrared LED. So the history of pupillometry runs in conjunction with the history of research surrounding the pupillary light reflex. But for the purpose of this, I'm going to solely focus on the developments in pupillometry, albeit briefly. I'm going to pick on some key points in the development and what got us to where we are now. So, pupillometry has been around for centuries. It can be traced back to the 2nd century when the Greek philosopher, physician, and surgeon Galen performed cataract surgery. You'd occasionally get patients who came to him that were beyond help, so he required a predictive indicator to help know what the outcome of the surgery would be, so he could avoid tarnishing his reputation. He noticed that pupils were small when they were exposed to light, and then they enlarged again when covered. He started to cover one of his patient's eyes and search in the opposite eye for small but significant signs of consensual dilation, as that would indicate that the surgery would be a success. This test was used for centuries, but didn't determine what the exact size of the pupil was. He only looked for significant but small dilations. If we move forward to the 16th century, Galileo Galilei developed a geometrical method to determine the size of the pupil, which involved 2 pieces of paper that were identical in size and shape, however one white and one black. The black piece would be placed at a fixed distance from the observer, and the white would be moved until the observer viewed it as just covering the black paper. Pupillary size was then calculated based on the difference between the measured and the perceived distance from the white paper. This has been simplified over the years, since it is quite an overly complicated method, to simply measuring the pupil size with the compass. So if we move on to more modern pupillometry, in 1897, Garton was instrumental in the development of using invisible radiation to photograph in relative darkness, for which he used ultraviolet radiation. Now, I know what you might be thinking, that ultraviolet radiation might not be the safest to use around the eyes, so infrared radiation is now what is used in this kind of respect. Moving further along to 1905, Wheeler created a mechanism that allowed him to capture 10 images per second, and this marks the first time that someone was able to capture the dynamics of pupil reactivity. And then finally, In 1957, Lowenstein and Lowenfeld are credited with building the first electronic pupillometry that used infrared technology. This pupillometer is the basis of modern-day pupillometry. There are two main forms of pupillometry that currently exist. The first of which is dynamic pupillometry, which is the direct descendant of the first electronic pupillometer created in 1957. It involves recording and quantifying the dynamics of the pupillary light reflex across a light and dark cycle. This is achieved through the use of infrared videography, as infrared light is outside the visual spectrum, therefore does not elicit a pupillary reaction. It's very useful in assessing the sympathetic and parasympathetic branches of the autonomic nervous system. It has been used in lots of research across a range of different conditions, including Alzheimer's disease, schizophrenia, autism, and traumatic brain injury. The other main form of pupillometry is chromatic pupillometry. This involves using different wavelengths of light to preferentially stimulate different photoreceptors in the eye. This is important as rod, cone, and intrinsically photosensitive retinal ganglion cells have different roles in mediating the pupillary light reflex. It's often used in research that regards eye conditions, including optic neuropathy, retinitis pigmentosa, diabetic retinopathy, and glaucoma. Most research that tends to utilize chromatic pupillometry solely focuses on the use of red and blue light as stimuli to preferentially stimulate the cone and rod photoreceptors respectively, although there is potential to go beyond this. Here is a figure depicting the peak activation wavelengths for the different photoreceptors in the eye. As you can see, there are three types of cone photoreceptors. You have your long, medium, and short wavelength cone cells, which names are derived from the length of the light wavelength that stimulates them. Now, purely using red light will mostly stimulate the L cones, and you won't see much activation from the S cones or the M cones, which contradicts people when they use just purely red light to activate cone cells. We also got to keep in mind the luminance of the light, as you can notice on the figure, that none of the cone cells are active in scotopic conditions. So when it starts to get dark, you only have activation in the rods, which are the photoreceptors that provide vision at night. We also noticed that the rod cells and the intrinsically photosensitive retinal ganglion cells have a very similar peak activation wavelength, which you can notice when you use blue light in pupillometry studies, because this period that's called pupil escape tends to be flatter when blue light is used, and you'll see that in the next graph. When you acquire data from a pupillometer, you can plot it onto a graph, and it will look a little something like this, which we call a pupillogram. Now, you acquire lots of information that speaks to the dynamics of the pupillary light reflex. When you begin your pupillometry study, you begin with a dark accommodation period. It could be 5, 10, 15 minutes long. That will allow you to obtain the baseline pupil diameter. Naturally, there are small fluctuations in the baseline diameter that correlate with cognitive arousal. When the light is switched on, there is a brief pause before the pupil begins to constrict. This is referred to as a response latency. The pupil that will then constrict until it reaches the minimum pupil diameter. Another useful parameter to extract is the time to fully constrict, when you're looking from when the pupil first actually starts constricting to when it reaches the minimum pupil diameter. If you notice as well, when the pupil does begin to constrict, it does so quite rapidly before slowing down to reach the minimum pupil diameter. This is referred to as the maximum constriction velocity. You can also calculate the difference between the baseline pupil diameter and the minimum pupil diameter to find the absolute constriction amplitude. Once the minimum pupil diameter has been reached and the light remains on, the pupil enters a period known as escape, where it begins to slowly redilate due to the rod and cone photoreceptors desensitizing quickly. The constriction is only maintained then by the intrinsically photosensitive retinal ganglion cells. As I mentioned before, the peak activation for the IPRGC cells and the rod cells are very similar, so you would see a flatter, more plateaued line during that pupil escape if this was in response to blue light. After the light is switched off, the pupil begins to rapidly dilate, and we're able to calculate the absolute dilation velocity. To summarize this section, you know that pupillometry is a non-invasive measure of pupillary size and reactivity. That has been developed over centuries of research and practice, and in modern pupillometry there exist two main forms, that of dynamic and chromatic pupillometry. And there are numerous parameters to consider that relate to the pupillary light reflex and its dynamic nature. Now, I want to talk to you a little bit about the neurophysiology of the pupillary light reflex to help you understand how pupillometry could be used in carbon monoxide diagnosis. Let's start with the constriction pathway. This is controlled by the parasympathetic nervous system. So when light enters the eye, it interacts with the photoreceptors in the outer layers of the retina. A signal is then generated and sent down the optic nerve towards the optic chiasm. When it reaches here, the nasal retinal fibers cross to the contralateral side of the optic tract, and the temporal retinal fibers remain on the ipsilateral side. While some fibers will continue toward the lateral genicular nucleus in order to carry on its journey towards the occipital lobe, others will travel through the pretectal olivary nucleus in the dorsal midbrain and are projected to the Edinger-Westphal nucleus. Parasympathetic preganglionic fibers will then pass the signal along the oculomotor nerve before synapsing with the ciliary ganglion. From here, the signal is then passed along the postganglionic short ciliary nerves, which innervate the iris sphincter muscles, causing the release of acetylcholine at the neuromuscular junction and subsequent pupil constriction. On the other hand, you have the dilation pathway, which is a subcortical pathway that originates at the hypothalamus. Now, this is controlled by the sympathetic nervous system. But in the absence of light, you've got alpha-2 adrenergic activation causing the inhibition of the Edinger-Westphal nucleus, leading to the suppression of the parasympathetic innervation of the iris sphincter muscle and a reduction in released acetylcholine. At the same time, there is an activation of the alpha-1 adrenergic sympathetic pathway that follows a 3-neuron arc along the central and peripheral nervous systems. Again, starting at the hypothalamus, a signal is sent down through the midbrain along the central neuron, which synapses with the preganglionic neuron at the ciliospinal center of Budge. A signal is then sent ascending the spinal cord from T1 to C8 towards the superior cervical ganglion, synapses with the postganglionic neuron. Finally, the signal travels along the postganglionic long ciliary nerves, which innervate the iris dilator muscle, causing the release of noradrenaline at the neuromuscular junction and subsequent pupillary dilation. To briefly summarize these two pathways, if you consider pupil constriction to begin with, the iris sphincter muscle contracts while the iris dilator muscle relaxes. This is controlled by the parasympathetic nervous system, and its main neurotransmitter is acetylcholine. Whereas during pupil dilation, You have the iris sphincter muscle relaxing while the iris dilator muscle contracts. This is controlled by the sympathetic nervous system, of which noradrenaline is the main neurotransmitter. So if you take these things into consideration, we know that if anything causes a disruption to the acetylcholine or noradrenaline balance, it will likely influence the pupillary light reflex. And I think at this point you might be able to see where I'm going with this. Now that you understand what pupillometry is and how the pupillary light reflex works, you can start to understand how carbon monoxide exposure could be detected in this fashion. If we consider the known toxicological effects of carbon monoxide, we can start off by saying that we know the classic mechanism is its ability to bind to haemoglobin, reducing its oxygen carrying capacity. We also know there's reports of carbon monoxide causing subtle changes to a person's visual function that typically manifests similar to those seen in optic neuropathies. And if you remember before, I mentioned that chromatic pupillometry has often been used in research regarding optic neuropathies and the influence on the pupillary light reflex. We also know that carbon monoxide intoxication can result in central nervous system dysfunction, though we might not be clear on the exact mechanism behind it. It could be a result of the central nervous system having fixed oxygen needs that are just not being met because of the reduced oxygen carrying capacity thanks to the binding to hemoglobin, or possibly since the endogenous carbon monoxide contributes to the modulation of synaptic neuron transmission, that any presence of exogenous CO might cause a disruption to this system. But whatever it is, there are multiple ways in which the central nervous system could be affected by carbon monoxide intoxication. But what we do know is that disturbances in normal pupillary reactions have been reported since the early 1920s, and acetylcholinergic neuron function has been reported to be disrupted in some cases. So what we do know is that in some capacity, carbon monoxide intoxication affects the acetylcholine noradrenaline balance. So to get a better understanding of how pupillometry might be useful and aid the diagnosis of people exposed to carbon monoxide, then I'm going to give you some other toxicological examples of when pupillometry has been applied. It's been explored in relation to exposure to organophosphate, which are a class of compounds typically seen in nerve agents and insecticides. Research has explored pupillometry to assess the pupillary light reflex in patients exposed to sarin, soman, and diclovus. They act by inhibiting the cholinesterase in ocular tissue, causing an accumulation of acetylcholine, and triggers pupillary constriction or meiosis. This mode of action is seen through the penetration of ocular tissue, and not through systemic exposure via the skin or inhalation. If we consider another example, we have botulinum toxin, or what is typically used in Botox injections. I'm not sure if you know how it works, but what it does is it inhibits the release of acetylcholine at the neuromuscular junction. So if it comes anywhere near your eyes, it'll be typically taken up by the parasympathetic neurons at the ciliary ganglion or at the neuromuscular junction of the iris sphincter muscle, and results in mydriasis or pupil dilation. We also have case studies that have examined the effect of some of the nightshade family of plants that include what is commonly known as devil's snare and angel trumpet. With direct exposure to the ocular tissue, it resulted in mydriasis or pupil dilation. Finally, pupillometry has been used to investigate the pupillary light reflex following mercury intoxication, in which slower pupillary recovery was seen in intoxicated patients. What you see is in each of these examples, the acetylcholine or noradrenaline balance has been infected by the subsequent intoxication, and this has been reflected in the pupillary light reflex of the patients. To bring a close to this section of the presentation, let's look at the key points of why pupillometry would be a good biomarker. So we know that pupillometry offers insight into nervous system health, specifically that of the parasympathetic and sympathetic arms of the autonomic nervous system. We know that disruptions to the acetylcholine and noradrenaline balance can be reflected in the pupillary light reflex. And we do know that even at low concentrations, carbon monoxide intoxication can impair central nervous system function. Therefore, central nervous system disruption is likely to be reflected in the pupillary light reflex of a patient exposed to carbon monoxide, which makes pupillometry a strong candidate for a biomarker that could help develop improved diagnostic methods. So now, since we've looked at what exactly pupillometry is, looked at its history, the forms it takes, the data that's produced, the physiology behind the pupillary light reflex, and how carbon monoxide could influence that and making pupillometry a viable biomarker for carbon monoxide exposure, I can now talk a little about the project that we're currently working on. Now, I'm sure my final thesis will have a lovely long-winded scientific name when it comes to submit it, but in the meantime, we've tried to give the project a catchy name, so we've gone with PICO, which stands for Pupillary Evaluation of Exposure to Carbon Monoxide. It is fully funded by the CEO Research Trust, and the main aim of the project is to evaluate the use of a novel pupillometer as a sensitive indicator of low-level carbon monoxide exposure. Now, this novel pupillometer is made by combining the features of dynamic and chromatic pupillometry to create something we have so aptly termed chromodynamic pupillometry. This hopefully will allow us to examine the dynamic contributions of the different photoreceptors in the pupillary light reflex. So the project essentially exists in 3 phases. Phase 1 includes establishing the reproducibility of the pupillometer and optimizing the stimuli that we use. We're just establishing that it is a new form of pupillometry and that it works as we would expect it to. So the data is then currently being analyzed right now, and then once that's done, we'll move forward into phase 2, which will explore the dose response of carbon monoxide on the pupillary light reflex and allow us to determine the lowest concentration of carbon monoxide that has an adverse effect on the pupillary light reflex. Once that's done, we'll carry on forwards to phase 3, which will then look at the age effect on the pupillary light reflex of when people are exposed to carbon monoxide. I've also included a picture of myself wearing the headset, so you can see what it looks like. So what it is a standard HTC Vive virtual reality headset that has been retrofitted with binocular cameras that capture videos at 120 frames per second. It also is infrared LEDs placed inside it that will illuminate the pupil so the cameras can pick it up as they are able to record in the infrared spectrum. This project also includes the use of complementary measurements, as we will be looking at investigating the cognitive effects of low-level carbon monoxide exposure. In combination with a pupillometer, we have been using transcranial Doppler imaging, or TCD. It's a rapid, non-invasive measurement of cerebrovascular function that uses ultrasound waves to measure blood velocity. We've been using it to record blood flow in the middle cerebral artery, as there's research that noted the changes in blood flow there in response to CO exposure. It has very good temporal resolution as it's quick to acquire data and can do it in real time. But you cannot define structures, and it is quite tricky to penetrate the skull, so it does have questionable spatial resolution. You can actually only penetrate the skull in certain areas where the skull is thinner. These are known as acoustic windows, of which the human skull actually only has 4. On the other hand, we will be also performing smaller scale studies, doing smaller repeats of studies in phase 2 and phase 3, using a better known technique of magnetic resonance imaging, also known as MRI. Now, you know, this is a non-invasive technique that can generate 3-dimensional anatomical images of the cerebral tissue, and it does this using a strong magnetic field and radio waves. You can create detailed anatomical images that go deep into the body, so it has good spatial resolution. However, acquiring those images can be a slow process and doesn't always catch it in real time, so it does have poor temporal resolution. These 2 imaging modalities will provide complementary data that will help us understand the cognitive effects of low-level carbon monoxide exposure, and each do help make up for the other's shortcomings. And finally, to bring this lecture to a close, we know that pupillometry is a strong candidate for a biomarker for carbon monoxide diagnosis because of its ability to offer a window into the autonomic nervous system, of which CO exposure has been known to affect. Across this 3-year PhD project, we will develop this novel technique of assessing the effects of carbon monoxide on the pupillary light reflex while examining the cognitive changes. Also, the research is being performed in conjunction with established techniques in carbon monoxide research in order to help validate this research. And thank you. If you would like any more information after today, please do contact Adrian or myself. I can be found on LinkedIn, and thank you again for listening.